So this lecture is going to be on the child with genital urinary dysfunction. We're going to do a little bit of review, and then we're going to talk a little bit more about some of the more unusual things, and then some of the things that we see a little more frequently. Some of the differences, just a reminder, in physiology and anatomy of children that affects their genitourinary systems includes the fact that their kidney is large in relationship to the stomach. And so as a result of that, it's more prone to injury. So when kids fall or get hit in the kidney area, they're more likely to sustain an injury compared to an adult. The urethra is shorter, and that includes both in males and females. And so that makes the risk of bacteria entering the bladder causing urinary tract infections to be much higher. The glomerular filtration rate is slower in the infant, and so that means that they're at a higher risk for dehydration. The bladder capacity is about 30 milliliters in a newborn, and it increases to adult size by about 1 year of age. The reproductive organs are immature at birth until adolescence, when the sex hormones go into effect. When we're doing a history on a child, we want to look at past maternal medical history, because did mom have polyhydramnios? That means, did she have too much amniotic fluid? Did she not have enough? That's oligohydramnios. Most of the amniotic fluid that is present is actually made by the fetus urinating into the placental cavity. And so that's how we know whether or not the kidneys are working well or not, based on how much fluid there is. Now, with the polyhydramnios, what ends up happening with that is they pee and pee and pee, because they still get fluid from their mother through the umbilical cord. But what happens to keep the amniotic fluid at kind of an even level is that the baby swallows that fluid. Now, it sounds kind of gross, but that fluid is all sterile at that point. And so it's not the same as far as being full of waste products, because the placenta is taking care of the waste products. It really is losing more fluid than other things. Was mom diabetic? Whenever mom is diabetic, it increases the risk of abnormalities happening to the baby in all of the systems. Was mom hypertensive? Because her hypertension can decrease the blood flow to the placenta. Did mom use alcohol or cocaine? Cocaine in particular will constrict the vessels of the placenta and affect the growing fetus. Then we want to look at the neonatal history. Neonatal means those first 28 days after birth. One of the things that we want to know is, was there a single umbilical artery? Normally on a baby, we have two umbilical arteries and an umbilical vein. So we have 3 vessels in the umbilical cord. When there is only one artery, it is associated with renal dysfunction or abnormalities. And so that's one of the reasons we look for that single umbilical artery. Was there an abdominal mass? Is there a chromosomal abnormality or a congenital malformation? Because often the chromosomal abnormalities don't just affect one system of the body, they tend to affect multiple, and the renal system seems to be one that gets hit fairly easily. Then we look at family history. Is there a family history of renal disease, uropathology, chronic urinary tract infections, renal calculi, or a history of parental enuresis? When we're talking about that, are they bedwetters? Because if it Bedwetting tends to kind of run in families, and so if it runs in the family, then we don't get quite as concerned about it. When we're looking at a patient's history, have they had previous urinary tract infections or calculi? Do they have stasis of urine? Is there retention of urine in the bladder? Has there been a pregnancy? Because that affects, sometimes will cause injury to the urinary tract. Has there been sexually transmitted diseases or bladder cancer? We also look at medications like antibiotics. What type of antibiotics have they been on? Remember that antibiotics like vancomycin and gentamicin have renal toxicity. So if the kidneys are not working properly, is it because of antibiotics or other medications like anticholinergics or antispasmodics that this child has received at some point? Then have they had any kind of instrumentation, surgeries or dilations or something else done to the renal system, to the urologic system? What is their urinary hygiene like? Are they, if they're girls, are they wiping from the front to the back and not from the back to the front, bringing the bacteria up to that area that can cause UTIs? What is their pattern of elimination? Are they holding it for long periods of time and then having problems with enuresis? So all of these things are important to know as we go along. With the actual physical assessment, we're going to palpate the bladder to find out whether the bladder is of normal size. We also are going to palpate the abdomen by where the kidneys are to see if we're feeling an enlargement of the kidneys. And we're going to use percussion over the back where the kidneys sit, and also percussion over the bladder. When we're doing this palpation and percussion, we're going to look also to whether they're having burning on urination, if there's been changes in their voiding patterns, if the urine has a foul smell, if there's discharge vaginally or from the urethra that might lead us to think that there could be a sexually transmitted infection going on, if there's genital pain, irritation or discomfort, if there's blood in the urine, or if there's edema in general. Now remember, edema can be caused by changes in protein, and your kidneys, if they're letting too much protein be lost, then you're going to have edema. Also, we're going to be looking for masses in the groin, in the scrotum, or in the abdomen. If there's flank abdominal pain or cramps, nausea or vomiting, poor growth or weight gain. And when we're looking at the weight gain, it's usually not a gain related to fat. It's a gain related to fluid. If there's a fever, if there's been an infectious exposure, or whether or not there's been trauma in the last little while, and what has happened since that trauma. Some of the normal characteristics of urine, the color range can be anything from a pale, almost clear color to dark amber, depending on how concentrated it is. And also remember, there's bilirubin in the urine, and that's what gives it sort of that yellow color. So sometimes when there's liver problems, we'll see a change in the color of the urine as well. It should be clear, so when you're looking at it, it should not be cloudy at all, but clear to vision. In newborns, they produce about 1 to 2 milliliters per kilo per hour. When we're concerned about blood pressure in infants, we want to see a urine output that's at least 1 milliliter per kilo per hour. That shows us that the blood pressure is high enough to perfuse the kidneys. In children, the production tends to be about 1 milliliter per kilo per hour. Normal urinalysis, the pH should be between 5 to 9. And the specific gravity should be between 1.001 to 1.035. So this lower specific gravity that we have, the 1.001, would be usually a newborn or a young infant, because they don't tend to concentrate their urine very well. So we often see specific gravities in those young infants between 1.001 to 1.005. There should be less than 20 milligrams per deciliter of protein in the urine. The urobilinogen, or the bilirubin that's in the urine should be up to 1 milligram per deciliter. Again, this is what gives the urine that yellow color. There should be none of the following in the urinalysis. There should not be any glucose, there should not be any ketones, no hemoglobin, no white blood cells, no red blood cells, no casts. Casts are when we have bacteria. It actually is like a cast of the bacteria or the cast of the red blood cells that are there, and no nitrites. So we have a question here. The nurse is percussing the abdomen of a child and notes a dull sound indicating a full bladder. At what anatomic location would this sound be heard? Over the spleen, at the right costal margin, over the kidneys, or above the symphysis pubis? So of course the answer to this is that it would be right above the symphysis pubis. So in a child, the bladder, because they've gotten an adult-sized bladder in this little tiny kid, is going to be, it will sit above the pubic bones, and you will actually be able to feel the bladder on a young child. When you percuss the abdomen, a dull sound over the symphysis pubis indicates a full bladder. The dullness is usually heard over the spleen at the right costal margin, over the kidneys, and 1 to 3 centimeters below the left costal margin. And it can basically, if it's full, it's going to be dull. If it's empty, it should be a more hollow sound. When we look at urinary renal disorders, these are the things that we're going to be covering: urinary tract infections, enuresis, and various structural disorders, and we'll look at each one of those. With a urinary tract infection, it's one of the most common conditions of childhood. Remember again that their urethra is short, so it makes it much easier for them to get infections. About 10% of children have had a febrile UTI during the first 2 years of life. And most important host factor is urinary stasis. So if they're not going to the bathroom frequently enough to empty their bladder, they are more likely to get urinary tract infections. Uncircumcised males are at a higher risk, and there's a concept of asymptomatic bacteria in the urine tract. So if you think about it, there's a very small area between what has your normal flora in it and what is supposed to be sterile. So what we tend to think is that often that there's asymptomatic bacteria in the urinary tract, but the fact that we void helps to reduce the numbers of bacteria that's there, making it asymptomatic. So there's a number of classifications of UTIs. Asymptomatic bacteriuria is significant bacteria with no clinical symptoms. So basically, these kids probably aren't being worked up for a UTI. They probably have discovered this as they've been ruling out some other type of infection. Symptomatic bacteriuria is when there's bacteria in the urine with physical signs like dysuria and suprapubic discomfort, hematuria, and fever. Actually, you should also add the dysuria kind of includes the discomfort with voiding, but often there's spasms that go along with that in the bladder. An upper tract infection involves the renal parenchyma, the pelvis, and the ureters. And these infections typically cause fever, chills, and flank pain. The lower tract infections involve the lower urinary tract, and there's usually no systemic manifestation. So usually fevers aren't associated with it, or chills, just the discomfort with voiding. So when we talk about lower urinary tract infections, we're talking about cystitis, which is the infection of the bladder, and urethritis, which is the infection of the urethra. The upper tract infections are referred to as pyelonephritis or vesicoureteral reflux, which is not actually an infection, but it is a reason for pyelonephritis to develop. Also, glomerulonephritis is another form of upper urinary tract infections. There's also different types of UTIs. Recurrent means that they're having repeated episodes. Persistent is that there's still bacteria in the urine despite receiving adequate antibiotics. Febrile UTIs typically indicate pyelonephritis, and urosepsis is when you have febrile UTI that is coexisting with a systemic signs of bacterial infection or sepsis, and you actually find the urinary pathogens in the blood system. So if you think about how close, if you have a kidney infection, how close that membrane is in the kidney, how easy it would be to the blood flow, how easy it would be for that bacteria to get into the bloodstream. Some of the etiology and pathophysiology of UTIs, the most common organisms are E. coli, streptococcus, and occasionally fungal or parasitic pathogens. And again, the anatomic reasons are that there's a short urethra in girls, but also up to about the age of 10 in boys. So think about that this is the point where the penis and the testicles are the secondary sex organs are starting to grow. Up until that point, little boys are prone to urinary tract infections as well, but girls tend to be the ones who get it because the urethra is just so short in them. Also, with uncircumcised males, if they're not cleaning themselves well, they are more prone to infection as well. So if parents decide not to circumcise their little boys, they need to make sure that they know how to clean themselves so that they don't get these infections. Some of the physiologic and mechanical defense mechanisms that maintain sterility of the urine include emptying the bladder. There's some normal antibacterial properties of the urine and in that urinary tract itself. There's more IgA in those areas, just like there is in the bowel. Also, ureteral vesicle junction competence helps to prevent the urine from being contaminated, and also there's a peristaltic activity that is not so much related to the emptying of the bladder, but just this movement of urine forward. If there's an alteration in defense mechanisms, like an immunocompromised person, then that increases the risk of development of UTIs. Usually the organisms are introduced via an ascending route from the urethra. The less common routes are through the bloodstream or the lymphatic system. Another contributing factor is urologic instrumentation, and this allows the bacteria present in the opening of the urethra to enter the urethra of the bladder. So if this is a child that has to be catheterized regularly, like a child that has spina bifida, then that's going to increase the risk of them developing UTIs. Sexual intercourse promotes a milking of bacteria from the perineum and the vagina, and this may cause minor urethral trauma, which sets a child up for developing UTIs as well. Rarely they result from a hematogenous route or from the bloodstream. But for a kidney infection to occur from the bloodstream, you had to have had a prior injury to the urinary tract, such as an obstruction of a ureter or damage from stones or renal scars. So in children, they're going to have the same symptoms as an adult does when they get UTIs, although they do tend to vary a little bit depending on their age, or at least how the child tells you about them. You're going to see urinary frequency, fever if it's a pyelonephritis in some cases. The urine's going to smell really bad, and there may be blood or blood-tinged urine. And even with significant bacteria, a pediatric patient may have no symptoms or non-specific symptoms like fatigue or anorexia. So when we look at diagnostic studies, we're going to do a urinalysis, and we're going to be looking at several different things when we do that. We're going to do a dipstick, and it's quick, it's inexpensive. It's going to be looking for things like nitrites, glucose, proteins, and blood in the urine, which can be signs of infection. We're going to look at, they're going to do a microscopic urinalysis. So they're going to be looking at the urine under a microscope to see if they see signs of infection there, whether they see pus, whether they see bacteria itself there. Also, we'll do a culture, so we'll be waiting for it to grow. And usually we prefer a clean catch specimen because it's the least invasive way to get the urine. But sometimes that's hard on young children. So sometimes what we do on babies is we may put a urine bag on them for collection. So it actually is a plastic bag that has sticky edges on it that sticks to the skin so that hopefully they void into the bag and you catch it before the bag falls off. I can't tell you how many times I've put a urine bag on the kid pees and somehow they manage to get their urine to loosen up the bag, and I end up with, you know, maybe 2 or 3 drops in the bag and everything else in their diaper. So sometimes that's not the easiest way. We can catheterize a child for to get the urine as well. Or we can use a suprapubic needle for aspiration. Both the catheterization and the suprapubic needle aspiration is more accurate, although it may be positive for blood, nitrites, leukocytes, white blood cells, or bacteria because of the trauma that's involved with it. But it may be necessary when this clean catch specimen can't be obtained. So the picture that's sitting here shows you how the needle goes straight down into the bladder. They withdraw the urine from the bladder, and then it's pulled out. And I can tell you as a nurse practitioner, usually bedside nurses are not doing suprapubic taps. Those are usually done either by residents or the nurse practitioner or the doctors. And what we do is we prep the skin so that we're not taking skin bacteria into the bladder. And then literally that needle just goes straight in. On an infant, all you need is a 2-inch needle to get right into the middle of the bladder and get the urine back. And I've done hundreds of them, I hate to say, but usually the kids don't seem to feel them too much. They're more upset about being held down so that they don't kick and move their legs, causing us to go in the wrong spot. And then the sensitivity testing determines the susceptibility to the antibiotics. Usually they'll be covered with a broad spectrum antibiotic until we know what the culture comes back with. Once we know the sensitivity, then we can give the child the specific antibiotic that's going to take care of their infection. Imaging studies for suspected obstruction may be done in some children, but normally we're not going to do imaging studies. However, if you've got a kid, a boy especially, that's 10 years old or older that's got a urinary tract infection, they may want to do imaging studies so that they can be sure that they don't have some kind of abnormality that affects the flow of urine. The renal ultrasound may show hydronephrosis if the child also has a structural defect. VCUG usually is not performed until the child's been treated with antibiotics for at least 48 hours because the infected urine tends to reflux up the ureters anyway, and so the VCUG would not really be showing a true result until the urine is starting to become sterile again. Treatment for a urinary tract infection is going to be oral or intravenous antibiotics. It depends on the severity of the infection, whether they're giving oral or intravenous. If the child has a kidney infection and they're severely ill, they're going to be giving them intravenous antibiotics because they want to really get that antibiotic to the kidneys. Also, we'd be looking at wanting to make sure that these are antibiotics that are going to be cleared through the kidneys more than being cleared through the liver, because we want that antibiotic to be going through the kidneys. We also, depending on the urine culture and the urine sensitivity, that's going to also determine which antibiotic that is given. It's often given for a 7 to 14-day course, although occasionally with a milder infection, and depending on the antibiotic, they may be able to do a 2 to 5-day course. When we're looking at collaborative care, especially for antibiotics, for uncomplicated cystitis, usually it's a short-term course of antibiotics. For a complicated UTI, the long-term treatment is usually trimethoprim sulfmethoxazole, or what it's usually called as TMP SMX or nitrofurantoin. Amoxicillin may be given in some cases, cephalexin, and others like gentamicin or carbenicillin. Pyridium is an over-the-counter medication. It's also known as Azo, and it helps to relieve the spasms of the bladder so that there's less cramping and burning with urination. Also, there's combination agents like Uracid that also can be used to relieve pain. And there's also some preparations with methylene blue tint in it because the methylene blue helps to relieve some of those spasms. Both the pyridium and the methylene blue will turn the urine colors. The pyridium turns it sort of a dark orange, and of course, methylene blue turns it blue. So parents especially moms should be reminded about that. Most moms have had some kind of urinary tract infection and have probably had pyridium, but it never hurts to remind them that this can stain the underwear permanently, and so they may want to have them wear their older underwear that they don't care whether it gets stained or not, or also they may want to put a pad or something into the underwear so that if they dribble a little bit of urine, they won't stain their panties. Also, for repeated UTIs, the child may be put on prophylactic or suppressive antibiotics. And usually it's the TMP SMX that's administered every day at a low dose as a single dose before events that are likely to cause a urinary tract infection. The etiology and pathophysiology of acute pyelonephritis, so we'll take it on up the urinary tract, is that it's an inflammation caused by bacteria, fungi, or protozoa, or viruses that are infecting the kidney. The most frequent causes are E. coli, Proteus species, Klebsiella, or Enterobacter. It commonly starts in the renal medulla and spreads to the adjacent cortex of the kidney. And it can result in, if they have recurrent episodes, to scarring and poorly functioning kidneys and chronic pyelonephritis. The clinical manifestations of the acute pyelonephritis include very mild to more classic and severe symptoms. Usually they present with nausea, vomiting, anorexia, chills, nocturia, so in other words, they're peeing more at night, increased frequency and urgency, suprapubic or low back pain and dysuria, and fever, hematuria, and foul-smelling urine. Often there's costovertebral tenderness. So in other words, we have tenderness over the area where the kidneys lie, which is on the back vertebral area, where the ribs come down, the costal areas. The symptoms often subside in a few days, even without therapy, but the bacteria and the pyruria persist. So even though the nausea and vomiting and everything, they still have bacteria in the urine, and they usually also have the symptoms of dysuria and the like. Some of the diagnostic studies is a urinalysis, and with that urinalysis, we're going to see white blood cell casts in the urine. Also, we do complete blood counts, a CBC, imaging studies like an IVP or a CT scan, and ultrasound. When we look at collaborative care of acute pyelonephritis, In children, we usually will hospitalize them and they get parenteral antibiotics. Now, with adults, they can have a kidney infection, but they don't necessarily get put into the hospital just because they have a kidney infection. Relapses are treated with a 6-week course of antibiotics, and reinfections are treated as individual episodes or managed with long-term therapy. So in other words, each time that they're reinfected, it's as though that is their first time that they've gotten a urinary tract infection. But if they're having frequent reinfections, then prophylaxis may be used for those cases. Moving on to enuresis. So enuresis is most commonly known as bedwetting. It is more common in boys than girls, and it usually stops between 6 to 8 years of age. Although the technical term of enuresis means urinary incontinence beyond the age of toilet training. And it can be caused by physical or psychological causes. And so we need to also assess for family disruptions or stressors, a history of being difficult to arouse from sleep, a family history of enuresis, and the child's cognitive status. So when we look at the diagnosis, often we have chronologic or development age over 5 years, and 2 to 3 times they're having wet beds or accidents 2 to 3 times per week or more for 3 months or longer. They may have urgency or frequency as well, and they just are often what we see in toddlers, for instance, is that they are so involved in their play that all of a sudden it just hits them that they have to void, and they can't get to the bathroom fast enough in many cases. And so even though we say urgency and frequency, it may not be as much of an urgency as what we think because they've ignored signs up to that point. Some of the problems related to enuresis, there's primary enuresis, which is the onset of wetting in children who have never been dry for extended periods of time. So they never really had good control. Secondary enuresis is the onset of wetting after an established urinary continence. So this is a child that was not having any bedwetting or accidents, and then all of a sudden start having them. The monosymptomatic enuresis is the most common, and this is kids that are dry during the day, but they are wet at night. And the polysymptomatic enuresis is when there's daytime urgency, kind of like what I told you about the toddler. So back to, we mentioned about the normal bladder capacity and the fact that in infants that's only 30 mils, and that slowly by the time they're a year old, they have the same size bladder as an adult. Well, that bladder volume is about 300 to 350 milliliters, which is sufficient to hold a night's worth of urine. A child that's aged more than 2 years of age is expected, if you take their age and add 2 to it, that's the expected bladder capacity in ounces. So if I have a 2-year-old and I add 2, then their expected bladder capacity in ounces would be 4 ounces. 4 ounces would be about 120 milliliters for a 2-year-old. If you have a 5-year-old, you would take 5 plus 2, and the expected bladder capacity would be 7 ounces, 7 times 30 milliliters, 30 milliliters is an ounce. So if you take 30 times 7, you'd have 210 milliliters. So the volume of the bladder being at 300 to 350, a child that's 5 years old ought to be able to hold 210 mils in it. They might feel like they need to go, but they shouldn't be having accidents with that amount in their bladder. Some of the psychological factors that affect enuresis is that they may sleep more soundly than other children. So these kids, when they are out, they are out. And what ends up happening is when they have an accident, the bed starts out warm, but pretty soon it gets cold, and it's the cold that actually wakes them, the cold wetness that wakes them up, and they realize that they've wet the bed. In some cases, some children have actually dreamed that they've gotten up, walked to the bathroom, and went to the bathroom, but actually peed the bed. There can be emotional factors involved. If there's big changes going on in their lives, they're moving to a new city, they're going to be going to a new school. Maybe the family is, the parents are going through a divorce, or there's been a death in the family. All of those things can be factors that cause children that have previously had control to have enuresis. Also, like I mentioned before, if there's a history in the family where it took a long time for various members of the family to have overnight control, then it's more likely that it will happen to their children as well. When we look at treatment, we want to encourage the child to drink more during the day and less in the evening. If you don't have it in your bladder, you won't have to void it out. Also, set a schedule for voiding, or have them attempt to void throughout the day. I can't tell you how many times I've gotten ready to go somewhere with my kids, and I don't want to have to stop once we get on the road. And so I'll say, okay, everyone go to the bathroom before we leave. And of course, every time it's like, but I don't have to go. And every mom knows that you can sit kids down on a toilet that says that they don't have to go, and you start some water running and they will go. Just hearing that noise is good enough to get them going. So sometimes you have to do things like that with kids to get them to void throughout the day, or void at times that you're going to be going somewhere and you don't want them to have an accident. Limit bladder irritants like chocolate and caffeine. Both of those things will irritate the bladder and make the child more prone to have an accident. Also, limit fluid intake in the evening before bed. If they get lots to drink just before they go to sleep, that means that they're going to have to empty their bladder in a few hours. Also, wake the child to void prior to the parents going to bed. So if the kid is going to bed at 7 or 8 o'clock and the parents are going to bed at 10 or 11, the parents could go in, get the kid up, which is loads of fun again, take them to the bathroom and say, no, I just wanted to have you go to the bathroom one more time tonight. And then usually they'll go, and they're so sleepy that usually you can put them back to sleep and they'll doze right back off to sleep. Also, the use of bed pads or 2 sets of sheets to decrease the work when an accident does happen. So this is not putting one sheet down and putting another sheet on top of it, because basically the urine will just go through both sheets. But what it is putting down 1 set of sheets, then putting a waterproof pad over that one, and then putting another sheet on top of that. So that way the urine may go into the waterproof pad, but it won't go all the way down to that second sheet. And so then it's just taking the wet sheets off and not not having to take everything off of the bed. At home, have the child wear their own underwear, but when they're away, maybe some pull-ups or something like that, so that if they do have an accident, there's less embarrassment. Although as kids get older, wearing pull-ups is like wearing a diaper, and so it still is somewhat of an embarrassment for them. Let the child know that they are not the only ones that have this problem, because again, a lot of kids have these problems. Also, there's enuresis alarms that basically they sense the wetness, like there's a sensor that's on the child's underwear or pajamas, and they will sense the wetness, and then it makes an alarm so that hopefully the kid stops their urination and goes to the bathroom. I don't know how well those actually work. And then there's drugs like imiprimine, which is tofranil, oxybutynin, or desmopressin that will help to control the urine output. We have a little case study here, and just kind of think about some of these questions. A mother of a 7-year-old is doing laundry and notices that her son has 3 pairs of pajamas in the hamper. After checking the bed, she realizes that he is wet in the bed at night. How should the mother approach the problem of her 7-year-old's bedwetting? So we want to make sure that we're looking at developmental ages. So remember, at 7, they are at the industry versus inferiority stage. And so children at this age are moving towards achieving competence. So if they feel that they're inadequate or inferior, they may not feel like they're meeting their parents' expectations or the standards that have been set for them. So they should not be compared with other children or other siblings, because this is also the time when the children learn to be either competitive or cooperative with others. And if they have older siblings, probably the older sibling's going to be making fun of them anyway, which is going to be making them feel inferior. Also, we want to consider that this condition may have an organic cause, and so going to the pediatrician is in order to rule out a urinary tract infection, which could be causing the problem. And then the family history is needed because the nocturnal enuresis, she may find out that dad used to pee the bed until he was 9 years old. So we definitely want to do more assessment in this case. So what strategies should the nurse discuss with the parents to help improve the problems of enuresis? So in your book, in box 17.1, it talks about having the child empty their bladder immediately before going to bed, restricting fluids, avoiding fruit juice and juice drinks after 4 p.m., avoiding caffeinated or carbonated beverages after 4, offering only sips of water before bedtime if the child wants to have a good night drink, and allowing the child to wear regular underwear and avoid the use of diapers or pull-ups, because that again has that issue with feeling inferior to others of his age. And there's more things in that list, and so just kind of take a look at that as ways to help children that have problems with enuresis. And so now we're going to move on to bladder exstrophy. This is a congenital defect, and I'm not sure whether this is actually in your book or not, but I wanted to add this in mostly because I had questions about this from students when they were taking OB classes because they didn't quite understand everything that was involved with it. And basically what happens is when they're born, the bladder is outside of the body. Usually other parts of the urinary tract system is outside as well. And These particular pictures are not before and after pictures, because I think that this one picture is actually a little girl and this is a little boy over here. You can see his testes hanging there. And the nursing care involves keeping the bladder moist and prevention of infection prior to surgery. The surgery involves reconstruction of the bladder if they're able to do that. And usually they put stents in after the surgery to allow the bladder to heal. And so it's a pretty rare thing. I've only seen one baby with this in 30 years of being a NICU nurse. So just to give you a general idea of how rare it is. But I did have to take care of that baby with the ureteral, the stents in the ureters to prevent the urine from building up in the bladder and causing problems with the healing process of the bladder. Hypospadias, and I think I got this backwards because I had to do some shuffling of these slides. So I'm going to move on to this next slide, but then come back to this one. The hypospadias and epispadias is when the urethra does not exit at the tip of the penis as it should. And with these babies, no circumcision is done because the foreskin tissue is used for the repair. And the repair is usually done when the child is 1 year old. And during that time, they do the circumcision so that they have that foreskin as a repair. Hypospadias means that the urethral entrance is on the lower side, the downside of the penis. And epi means that it's above or on top of the penis. And there actually are females that have epispadias, which actually puts the urethra above the clitoris. But that's an extremely rare thing where hypospadias is the most common, and it's in boys. When we're taking care of these kids post-operatively, they will have a urinary catheter or a stent in to make sure that there's no adhesions of the urinary tract. And so we have to make sure that the drainage is appropriate from the stent and keep the area clean. One of the things that we use is a double diapering technique. And so basically what we do is to put the catheter through the diaper and then with a hole in the diaper, and then put the penis through that as well, and then put another diaper over that because we're trying to keep the surgical area from getting stool on it. Usually the penis is put in a straight upright position, but the surgeon may basically will tell you exactly how he wants that penis positioned. And they do that to decrease pressure on the incision side. So you can imagine with a hypospadias that it's going to be more of an up position of the penis, where with an epispadias it would be more of a downward position so that there would be less pressure on the upper side of the urethra. Usually they're given prophylactic antibiotics, pain medications, and antispasmodics so that they're comfortable. With a hydrocele, it is a buildup of watery fluid around one or both of the testicles. And so if you look at this picture, we have the normal one here on the left, and there's a little bit of fluid that should be in the scrotum. But with the non-communicating hydrocele, we've gotten fluid that's come from the abdomen down into the hydrocele or into this scrotum, and then the space closes up and it traps the fluid inside. Usually with this case, the body absorbs the fluid over time and it goes away. With the communicating hydrocele, the space doesn't close up the way it should, and the fluid moves back and forth between the scrotum and the abdominal area. And so the swelling comes and goes. And this problem is usually fixed with surgery to help prevent herniation. And then you can have a hydrocele of the cord, of the spermatic cord. And in that case, what happens is that it's higher up in the scrotum, and often it's not a communicating type of hydrocele. And that one will usually resolve on its own once the fluid reabsorbs. So usually, as far as looking at surgery, if the little guy still has a hydrocele at age 2, then they'll do surgery. If the swelling comes and goes, that's another, because it's communicating, if the swelling is causing pain or the swelling gets worse. I've seen some pretty large hydroceles on little guys that have had hernias because it's associated with hernias, and their poor little scrotums are just gigantic. But when they go in and do the hernia repair, they also do the hydrocele repair, and the fluid that's still there is reabsorbed. A variocele is similar to varicose veins in the legs, but it's the veins supplying the testes. And the varicele most often occurs in the left testicle. And they think that may be because of the angle at which the blood from the scrotum enters the kidney veins, and it can cause pressure to build up in the scrotum. In most cases, there's no symptoms, and when the symptoms do occur, they can include a heavy feeling in the testicles, or a dull ache in the scrotum, or one testicle that's smaller than the other. Treatment may be done to ease the discomfort and pain, and some of the treatment includes laying flat on the back, which helps the blood flow in the right direction and drain away from the scrotum. Underwear that supports the scrotum. This could be an athletic supporter or briefs. Pain medication, things like over-the-counter medications like ibuprofen or acetaminophen can help lessen the discomfort. And then surgery or some other method to take out or block the vein with the variocele. It can restore the proper blood flow in the scrotum and help preserve the ability or the fertility for later. Both with the hydroceles and the varicocele, there's because of the increased warmth around the testes, if it's not taken care of when the boy is a child, it can affect fertility later on in life because the sperm are too warm. And so sperm don't like to be warm, and so they die or they move really slow. And so then often they find with infertility where it's something going on with the male, that it's a hydrocele or varicocele that's causing it. Hydronephrosis is the dilation of the pelvis and the calyces of a kidney due to a buildup of urine. And it happens when the urine cannot drain out of the kidney to the bladder from either a blockage or an obstruction. The hydronephrosis can occur in one or both of the kidneys, depending on where the blockage is. Some of the symptoms include failure to thrive, intermittent hematuria, an abdominal mass, signs and symptoms of urinary tract infections, frequent UTIs. When they talk about the abdominal mass, if they haven't already seen hydronephrosis on fetal ultrasound, which fetal ultrasound is getting really good, and we're seeing hydronephrosis before kids are even born. But if for some reason they missed that, often on exam, the pediatrician will feel a mass where the kidney should be, and then after doing an ultrasound to visualize it, they see this hydronephrosis. They can do avoiding cystourethrogram to visualize the obstruction, although usually that's not done in infancy, and most of these hydronephrotic cases are discovered during infancy. Usually the renal ultrasound will show them what they're looking for. It's not unusual for them to have the valves of the ureters to actually be backwards to the way they ought to be. So instead of letting the urine go down and keeping it from refluxing back, it actually keeps the urine from going down at all. And so then it builds up and causes this hydronephrosis. When we look at nursing care, we teach the parents the signs and symptoms of a UTI, to watch for the adequacy of urine output and hydration status, how to perform appropriate perineal hygiene, because again, it could be a male or a female that has it, and since there's stasis involved, if they're not voiding adequately or they're wiping the wrong direction, it could definitely cause UTI to form. Also, to make sure to follow up with the pediatric urologist or nephrologist as scheduled. Somewhat related to the hydronephrosis is vesicoureteral reflux, or VUR. And this is an abnormal retrograde flow, meaning that the urine is flowing towards the kidney instead of away from it. And so the urine from the bladder flows up into the ureters. When voiding, the urine is swept back up into the ureters and the bladder, where it becomes a reservoir for bacterial growth until the next void. And it's one of the major reasons for hydronephrosis, and is usually ruled out as part of the workup for hydronephrosis. So the goal of therapy is prevention of pyelonephritis and renal scarring. There's two types: primary, which is a congenital abnormal insertion of the ureters into the bladder, or a secondary reflux, which is the result of some type of acquired condition. The VUR nursing management is preventing infections. So initially it's managed medically with low-dose Bactrim, and usually the dose is given at night, since that's when there's the most stasis of urine in the bladder, even for children that are infants that are not potty trained, and that the parental education is the same as for hydronephrosis. Urine culture is usually done every 2 to 3 months, or anytime the child has a fever, and a VCUG is used to assess the status. As far as the prognosis goes, most children outgrow VUR, but for more severe forms, they may need surgical intervention. As far as providing post-op care after surgery, The IV rate is usually 1.5 times the maintenance, and you all know how we figure out maintenance IV fluids. So we're wanting these kids to void frequently. We want to monitor the urine output, and they'll have a Foley catheter in, at least initially after surgery, and administer analgesics and antispasmodics as ordered. We want to encourage ambulation and advancement of the diet to prevent constipation, because we're probably going to be giving them some opioids, at least initially. We also want to teach the parents how to give the antibiotics. Nephrotic syndrome is a little different than what we've been talking about up to this point. And this is when the body secretes too much protein in the urine, and it causes decreased protein in the blood, which causes edema to occur. The liver, sensing that the albumin levels are low, increases the lipoproteins, causing hyperlipidemia. So we've got a whole lot of stuff going on. We have edema because there's not enough protein in the blood. The albumin levels are low. And then at the same time, because of these lipoproteins trying to pull that fluid back into the circulating blood, these kids end up with high cholesterol levels. Most cases are caused by damage to the glomerular vessels. And children with nephrotic syndrome are at increased risk of clotting due to decreased intravascular volume. They are also at higher risk of infection, and they're also at risk for acute renal failure if they have steroid-resistant nephrotic syndrome. So your book has this little chart in it that shows how nephrotic syndrome happens, and most of the time the most common presentation is that there's been some kind of glomerular injury in the children. So if you think about things that we've already talked about, UTIs are the most common reason for there to be a glomerular injury, meaning that they've had a kidney infection. Some of the characteristics that we see with nephrotic syndrome is massive proteinuria. So in other words, when we check a protein in their urine, it's going to be very high. If we do 24-hour protein levels in their urine, we're going to see very high amounts of protein in them. With all that protein in the urine, we don't have protein in the blood, and so there's nothing to keep that fluid in the intravascular space, so it's all out in the interstitial areas. They also have the hypoalbuminemia, hyperlipidemia, and edema. There's different types of nephrotic syndrome. The minimal change nephrotic syndrome is the most common type. It's also known as idiopathic nephrosis, childhood nephrosis, or minimal lesion nephrosis. It constitutes 80% of nephrotic syndrome cases. The secondary nephrotic syndrome is a known or presumed cause. And then there's actually a congenital nephrotic syndrome as well. But the symptoms are all the same. The pathophysiology is that it occurs predominantly in children between the ages of 2 and 7 years of age. It's rare in children younger than age 6 months and or older than the age of 8. The cause and mechanisms are not truly known, but the components that are thought to be metabolic, biochemical, physiochemical, or immune mediated. Basically, the glomerular membrane normally is impermeable to large protein, but it becomes permeable to proteins, especially albumin. The albumin is lost in the urine, which is how we get that hyperalbuminuria, and the serum albumin becomes decreased. So we have hypoalbuminemia. And so then the fluid shifts from the plasma to the interstitial spaces. We have symptoms of hypovolemia because of all this fluid out of the intravascular spaces, and the child develops ascites. The diagnosis is suspected based on clinical manifestations of the generalized edema that develops gradually or in some cases rapidly, that there's proteinuria of 2+ or more on a dipstick test, that there's hypoalbuminemia, hypercholesterolemia, in the absence of hematuria and hypertension, and that there's low serum protein and sodium. It may require renal biopsy to distinguish it from other types of nephrotic syndromes. As far as management goes, supportive care is necessary. The diet should be low to moderate in protein, and sodium restrictions when there's a large amount of edema present. Steroids are the first line of therapy. The dose is usually 2 milligrams per kilogram divided into twice-a-day doses. Prednisone is the drug of choice. It's the least expensive and the safest. Also, immunosuppressant therapy, if it's an immune problem, is often used, and diuretics to get rid of that edema. As far as some of the family issues associated with MCNS, we have because it's a chronic condition, we're going to have relapses. So this kid goes in and out of the hospital fairly frequently. We need to make sure that developmental milestones are being met. There may be social isolation due to lack of energy, immunosuppression, so we're trying to protect him from getting sick, and changes in appearance due to the edema can affect their self-image. When we look at the nursing interventions, aseptic techniques during catheterizations are going to be especially important, and we avoid unnecessary catheterization and make sure that there's early removal of indwelling catheters. We want to prevent nosocomial infections, so washing hands before and after contact, wearing gloves for the care of the urinary system or the catheter system. We want to do routine and thorough perineal care for all hospitalized patients, but especially these guys, and avoid incontinent episodes by answering the call light and offering the bedpan at frequent intervals. In addition, we want to ensure adequate fluid intake, that the patient with urinary problems may think drinking fluids will be more uncomfortable, but what it does is it dilutes the urine and it makes the bladder less irritable if they drink more, and it flushes out the bacteria before it can colonize. We want to make sure that they avoid caffeine. Obviously we're talking about peds here, but these kids grow up into adults that still have this problem. So also avoiding alcohol. Citrus juices, chocolate, and highly spiced foods also irritate the bladder, and so we want them to avoid those. Discharge to home instructions include follow-up urine cultures. Recurrent symptoms typically occur 1 to 2 weeks after therapy, and encourage adequate fluids even after an infection. Low-dose long-term antibiotics to prevent relapses or reinfections may be ordered, and explain the rationale to enhance compliance. because we know that if you don't know why you're doing something, you probably aren't going to keep doing it. Acute glomerular nephritis, or AGN, there's two types. There's post-infectious, which is associated with pneumococcal, streptococcal, or viral infections, or it may be a primary event, or it may be a manifestation of a systemic disorder like lupus, sickle cell, or some other disease. The symptoms are generalized edema due to decreased glomerular function, especially in the periorbital area around the eyes. Facial edema is more prominent in the morning, so that makes sense because basically this child has been laying down flat, so all the areas that are flat or down are going to develop edema, and then the edema itself is going to kind of even out across the body. So the facial edema is more common in the morning. And then throughout the day, it spreads to involve the lower extremities and the abdomen because, again, gravity is pulling it down. Hypertension due to the increased extracellular fluid is common, and oliguria, meaning not as much urine, is common as well. Bleeding in the upper urinary tract will result in the urine appearing smoky brown, resembling tea or cola. And I just really want to emphasize this because this is a disease process that exists in adults as well. And it's not uncommon on standardized tests or on NCLEX to have a question where they're asking about glomerulonephritis and they're asking about this tea-colored urine. And so definitely this is something unique with AGN. Also, proteinuria is reflecting the severity of the renal disease. With acute post-streptococcal glomerulonephritis, or APSGN, it's an immune complex disease, and it occurs before, it occurs after a strep infection, and usually it's a strep A infection. So what ends up so strep A can cause a couple different things, and when we get into the cardiac section, we'll be talking about rheumatic fever, and that's also related to group A strep infections, but it also can cause this glomerulonephritis. Usually there's a latent period of 10 to 21 days between the group A infection and the manifestations of the glomerulonephritis, and it can occur at any age. In children, it's more common in 6 to 7-year-olds. It's uncommon in children that are younger than 2 years old, and it's more common in boys, almost twice as common. The nursing management includes to monitor for acute hypertension. So we're going to monitor blood pressures every 4 to 6 hours. We're going to manage edema by doing daily weights, accurate I&O, and doing daily abdominal girths because, again, we're worried about ascites with this. We're going to watch nutrition that's going to be low in sodium and low to moderate in protein, which is one of those things that kind of seems off because here they are losing protein, but I'm not going to give them much protein. But that's just what we have to do. And then watch for susceptibility to infections. Bed rest isn't necessary for this disorder. So we have a question. The clinical manifestations of nephrosis includes which of the following? Hematuria, hematuria and weight gain, gross hematuria, albuminuria, and fever, hypertension, weight loss, and proteinuria, massive proteinuria, hypoalbuminemia, and edema. And of course, we know from having just studied it that the answer is D, that nephrosis is associated with massive proteinuria, hypoalbuminemia, edema, and hyperlipidemia. The hematuria, bacteriuria, fever, hypertension, and weight gain are not usually associated with nephrosis. Hemolytic uremic syndrome, when we look at it, we're going to talk about each one of these things. And it is usually something that happens after a diarrhea illness. It can be idiopathic, it can be inherited, it can be related to ingestion of certain drugs, it can be associated with malignancies, transplantation, or malignant hypertension. The symptoms are pallor, toxic appearance, so in other words, a septic appearance, edema, oliguria, or anuria. So this person is either not urinating at all or very little. They have elevated blood pressure, abdominal tenderness. Often there is neurologic involvement, which includes irritability, altered levels of consciousness, seizures, posturing, and comas. As far as the nursing management is concerned, we want contact precautions for infection, and we want to maintain appropriate fluid balance. So we're going to watch the strict INO, monitor the blood chemistries, administer diuretics as ordered, and assess blood pressure frequently. We're going to administer antihypertensives as ordered and encourage good nutrition and monitor for bleeding. As far as prevention goes, proper hand washing and teaching children to wash their hands after using the bathroom or being outside is especially important. You want to encourage the use of swim diapers for children that are not toilet trained, although honestly, I'm not sure whether it really keeps that out of the pool, to be completely honest with you on that, but that's what people say. You want to teach parents to thoroughly cook all meats to a core temperature of 155 degrees, wash all fruits and vegetables, ensure that the drinking water is treated appropriately, avoid unpasteurized dairy products and fruit juices, including ciders. When we look at restoring their fluid and electrolyte balance, we're going to monitor vital signs frequently and assess urine-specific gravity. We're going to maintain strict records of INO, administer diuretics as ordered, and when the urine output is restored, the diuresis can be very significant. So in other words, they are just going and going and going and going, losing that fluid that they're hanging on to. We want to monitor for signs of hyperkalemia and hypocalcemia. If they have hyperkalemia, we may need to administer polystyrene sulfonate, which is also known as Keyxalate, which is how we remove excessive amounts of potassium from the system. Obviously, we don't want them to have hyperkalemia because it's going to affect their heart and the electrical conduction of their heart. We want to administer packed red blood cell transfusions as necessary, and dialysis may become necessary in some cases. Remember too that although we talk about giving Keyxalate, it wouldn't be uncommon to see insulin given because insulin drives potassium out of the into the cells, which would drive it out of the circulating intravascular system and would decrease the hyperkalemia. Wilms tumor is a malignant renal and intra-abdominal tumor of childhood. It's also known as nephroblastoma, although most people call it Wilms tumor. It's 3 times more common in African American children than Caucasian children, and the peak age of diagnosis is about 3 years of age. It's also more frequently found in males than females. The etiology of Wilms tumor is that it is it's a tumor that arises from an embryonic source. We do ultrasounds and CT scans to see it. The therapeutic management is surgical removal, chemotherapy, and radiation. In some cases, they may, if it's small enough, they may do radiation rather than chemotherapy. And so the nursing considerations are going to be those that, same as with other renal problems, watching urine output, and for signs and symptoms that would be associated with problems with the renal system, as well as prevention of infection with a child that's on chemotherapy. With renal failure, it's a condition in which the kidneys cannot concentrate urine, conserve electrolytes, or excrete waste products. It can be acute, and we call that ARF, or chronic, which is CRF. When acute renal failure continues to progress, it becomes chronic, which is also known as end-stage renal disease, or ESRD. Dialysis and kidney transplantation are the treatment modalities used for end-stage renal disease. With acute renal failure, the definition is that the kidneys are suddenly unable to regulate volume and composition of urine. And it's not common in children. However, it's not uncommon either, because I think about how you can have acute renal failure related to medications like gentamicin or vancomycin or indocin that's being given for another purpose in neonates. And so it's not all that unusual in infants. The principal feature is oliguria, which means that they aren't voiding sufficient volumes. It's associated with azotemia, metabolic acidosis, and electrolyte disturbances. The pathophysiology of acute renal failure is usually reversible. And when we start talking about the cardiac defects, and I start talking to you more about the use of indomethacin, which is indocin, for patent ductus arteriosus, we'll talk about how that can cause acute renal failure. Usually, unless I just keep giving the drug and damaging the kidney, the urine output will pick back up again, and the kidneys will be fine without any long-term problems. Diagnostic evaluation is primarily based on history, as far as what has gone on, what could possibly be causing it, and the fact that there is oliguria after some event. And therapeutic management is supportive to encourage urine output. They may decrease fluid intake until the kidneys recover and begin to produce urine again. Nursing considerations: watching strict I&O, signs and symptoms of edema and fluid overload. Some of the complications associated with the ARF include hyperkalemia, that's usually the most immediate threat, hypertension caused by increased volume, anemia, which is not really an anemia, but more of a dilutional anemia, seizures from decreased from too much fluid, water intoxication, cardiac failure with pulmonary edema, and the tendency to develop water intoxication and hyponatremia, which is why the seizures are happening. With chronic renal failure, it begins when diseased kidneys cannot maintain the normal chemical structure of body fluids. So they are no longer adding sodium and potassium back to the blood. And it progresses to a clinical syndrome called uremia. So basically, it's as though urine is in the blood. Some of the potential causes of chronic renal failure is congenital renal or urinary tract malformations. VUR is associated with recurrent UTIs, which can cause chronic renal failure, chronic pyelonephritis, or chronic glomerulonephritis. Chronic renal failure is diagnosed by labs and evaluation of the urine, like 24-hour urines and other things like BCUGs and other radiology studies. The therapeutic management is to manage diet, control hypertension, and treat recurrent infections and seizures. So as a nurse, we're going to pad the beds if they have a history of seizures so that they don't hurt themselves. We're going to treat their recurrent infections and watch for signs and symptoms of those infections coming back if they have just been treated, and give their hypertension medications and make sure that they're eating the appropriate diets. Often with chronic renal failure, children will suffer from depression and anxiety, and the nurses should refer the children and their families to the hospital social worker or the counselor as needed for these depression and anxiety issues. This particular child is getting hemodialysis, and so they have a port in their chest that they are able to tap and give them their hemodialysis. The nursing goals for a child with end-stage renal disease is to promote growth and development, remove the waste products and maintain fluid balance via dialysis, and to encourage psychosocial well-being, all the while supporting and educating the family. Dialysis may be delivered by peritoneal dialysis, hemodialysis, or hemofiltration. And again, this little guy is getting hemodialysis. And you can see his dialysis machine back there, and he also has a port up in his chest. Peritoneal dialysis is the preferred method of dialysis for children. The abdominal cavity acts as a semi-permeable membrane for the filtration, and it can be managed at home in many cases. Your book says some, but really in many cases. The warmed solution enters the peritoneal cavity by gravity and remains in the abdominal cavity for a period of time where it picks up the waste products and the electrolytes that are too high in the blood. And then when the time period is over, then that fluid is drained back out of the child. So what you can see here is you have a bag that contains the dialysis solution, and then the catheter that goes into the abdomen, and then the drain line coming out. Hemodialysis requires the creation of a vascular access and special dialysis equipment. It's best suited for children who can be brought to a dialysis facility 3 times a week for 4 to 6 hours. So this is not something that is just sort of, oh, la, 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 it's no big deal. This is a large time investment. It achieves rapid correction of fluid and electrolyte abnormalities during this time. Transplantation can be from a living related donor, and those are actually not preferred, which is kind of odd to think about it, but it's not preferred because they can develop antibodies against antigens that are familiar, which is kind of an odd thing. From a cadaver donor that is the same blood type and matched as closely to other antigens that may be present in the child. And the primary goal is long-term survival of the grafted tissue. There is a huge role with immunosuppressant therapy, meaning that they're going to be on this for the rest of their lives. This will cause a child to have growth. They won't grow as tall as they would have otherwise because of the action of the immunosuppressants, and they are going to be more prone to infections. And there are other side effects that are associated with immunosuppressant therapy as well. So now we're going to talk a little bit about some of the reproductive organ disorders in teenagers and young and children. And we're not going to spend a lot of time talking about them because you'll get a little bit of this in OB, but just felt like I had to add some of these things in since your book talked about them. Labial adhesions are actually fairly common in young girls, usually because they aren't wiping themselves or cleaning themselves well enough. And so the labia majora and the labia minora will actually fuse together in some cases. These can be separated by applying estrogen cream to the area, and that will cause it to let go. But it can be very painful. And then we're going to talk a little bit about vulvovaginitis and pelvic inflammatory disease and some menstrual disorders as well. The causes of vulvovaginitis is bacterial or yeast overgrowth, and related factors are chemical factors like bubble baths, soaps, or perfumes that are found in personal care products. Poor hygiene can also play a role, and tight clothing that can cause a heat rash in the perineal area or persistent scratching of the irritated area may result in superficial skin infections. The treatment of vulvovaginitis is to teach appropriate hygiene as far as daily hygiene and toiletry. Wear cotton underwear and change it at least once a day, and administer topical or oral medications as orders. It's not a box on page 1659, but it is, I believe there's information in the adolescent area about other treatments. As far as manifestations of pelvic inflammatory disease, Often we talked about this a little bit on Monday when we were talking about infections and STIs. We often see fever, abdominal pain, pain with intercourse, dysmenorrhea or painful menstrual cycles, abnormal uterine bleeding, so bleeding at times that they are not having menstrual periods, and long-term complications include chronic pelvic pain, ectopic pregnancies, and infertility related to scarring. And if you look at this, you can see basically a picture version of what's sitting over there. Some of the causes of pelvic inflammatory disease, not sure why that Y ended up down there, is bacterial invasion through the cervix and the vagina, ascending into the uterus and the fallopian tubes. And the most common cause is gonorrhea and chlamydia. The treatment is intramuscular or oral antibiotics. Hospitalization is extreme if they are extremely ill, and that will mean that they're going to be on IV fluids, analgesic. Semi-Fowler position helps to lessen the pain, and it also promotes pelvic drainage. Also, education for prevention of reinfection. So basically, we're going to be talking to these girls about you got this by having sex, and whoever you had sex with had gonorrhea or had chlamydia, and that's why you have it. Disorders that are related to, as far as menstrual problems, primary amenorrhea or no menstrual periods is when there's no secondary sex characteristics and no menarche, which is the first period by age 14 to 15 years of age, or secondary sex characteristics are present, but menarche has not occurred by the age of 16 to 16 and a half. And so basically there's no uterine bleeding after attaining the sexual maturation for 1 year, after breast development for 4 years. Secondary amenorrhea is the absence of menses for 6 months or the absence of 3 cycles after menstruation was previously established. The most common cause, of course, is pregnancy, even with primary amenorrhea. And other causes are eating disorders, stress, or other causes of severe weight loss, like people that are athletes and have very low body fat. Dysmenorrhea, there's primary dysmenorrhea and secondary dysmenorrhea. However, the treatment is the same in that we're going to be using NSAIDs for pain. Estrogen therapy can help decrease the contractions of the uterus or even prevent them from having a period. Oral contraceptives can do that as well, and dietary changes. Also, exercises or heat are good comfort measures. Although most people want to avoid exercise when they hurt in their abdomen, it actually is something that helps with pain. When we look at male reproductive disorders, phimosis and paraphimosis is when the foreskin is adhered to the head of the penis. This is normal in a newborn. However, as the child gets older, it should not still be adhered. And so often they have to go in and remove the strictures that are causing the phimosis, and in a lot of cases they just go ahead and do a circumcision when they're doing that. And when circumcisions are done, they actually go in and break the phimosis, and that's what causes the oozing and the bleeding during the circumcision. one of the major things. Cryptorchidism, and we're going to talk about each one of these. We've already talked about hydrocele and varicocele, but we're going to talk about cryptorchidism, testicular torsion, and epididymitis. Cryptorchidism is when the testy has not descended into the scrotum. And you can see by this picture that 60% of the cases it's high in the scrotum, and if they go feeling around they actually can find it, and it will eventually fall down to where it's supposed to be. About 25% of them are in the inguinal canal, and another 15% of them are up in the abdomen. In the cases where they're in the inguinal canal or in the abdomen, they need surgery, which is called an orchiopexy, where they bring the testy down into the scrotum where it belongs, and they get it to be attached correctly. If they were not to remove, if they were not to bring the testes down to where they need to be, first of all, there would be infertility associated with it because the testes would be too warm, but also it increases the risk of testicular cancer. The post-op care is similar to that of hydronephrosis care, but the child needs to avoid vigorous activity, watch for signs and symptoms of infection, and pain control includes ice packs to the scrotal area and oral pain medications like ibuprofen or Tylenol in most cases. Testicular torsion is when a testicle is abnormally attached to the scrotum and it twists. And this requires immediate surgery because the ischemia that results from that, if the torsion is left untreated, can lead to infertility, not to mention that just that testy dies. It can occur at any age, but it most commonly occurs between the ages of 12 and 18. The signs of testicular torsion is a sudden strong pain in the testicle, swelling and redness, feeling sick or like they're going to throw up with this sudden strong pain. And the testicle that hurts may actually be higher than the other, which makes sense because if you think about that twist, bringing it up higher in the scrotum. The pain may go away, but then it comes back again. And like I said, it's most common in boys that are 12 to 18. So like I said, this is a surgical emergency. They need to get in there, get that untwisted, and then they will secure that testicle so that the twisting can't happen again. It would have post-op care that's similar to the orchiopexy that we talked about just a couple minutes ago. Epididymitis is inflammation of the epididymis, and it's caused by infection with bacteria. And it is the most common cause of pain in the scrotum. It rarely occurs before puberty, and if it does, it may occur as a result of a urethral or bladder infection related to a urogenital anomaly. Therapeutic management is directed towards eradicating the bacteria, and if it's left untreated, the boy can develop scrotal abscesses, testicular infarctions, and infertility can occur. So that concludes our lecture about urogenital issues in children, and I'll see you guys soon.